Hey, my coding family, how's everybody doing today? It has been a typical Monday. It is crazy around here. Hey, Samantha. Hey, Go-Kart. Good to see you guys. Hey, Mabel. How's everybody doing? Let's see. What page do I have set up here? Don't know. Do we have that one right there? Yeah. Here we go. Ooh, that's totally wrong. Okay, we won't do that one. Let's see what it does if it's that one. That one won't work either. Let's try that one. Ooh, that looks better. Hey, Zena, good to see you. Y'all work on this first practice question. See how y'all do while I get the books roaming around here. Oh, let's see. I have jury duty tomorrow, an hour away from my home. It is, let's see. So if I get picked for jury duty, then the trial is going to last a week. So I gotta go tomorrow. I've never gotten this far before where they actually want me to show up tomorrow. I did the survey, and because I don't have a job that I have to work anymore because I'm retired basically, I guess I got pushed through. I mean, it's an inconvenience, but it's not a hardship on me to have to go and spend a week. So I'm not sure. I don't know. But if I get picked, then this will be the only live for this week because I'll have to be in trial for the rest of the week. But we'll see. If I do be on this jury, then I'll be excused for 2 years. I usually get out of it every time. Last year I did because my mom fell and broke her hip, and I was like, I can't go. I'm not going nowhere. And then last 60 days ago, they tried to get me to go to a trial that's 5 hours away from my home. I'm like, dudes, no, I ain't traveling that far. And this one's an hour away from the house, so I decided I wasn't going to fight it, and I'll just show up and see what they have to say. It seems to be either military or police. They had a lot of questions about military and police, and my dad was military police, but that was back in Vietnam in like 1970, and he didn't pursue it as a career after he left Vietnam. He totally switched careers and never went into it, and that's the only person that's in my family that's ever been sort of kind of military or police. So I'm not sure what's going on in the trial, but that's all the info they gave me. But they let me pass through to be interviewed for tomorrow, so we'll see. So I want to make sure that you guys get a good lesson if this is the only one for this week. If you are going to take your exam this week or this month or anytime, I got cameras everywhere. One of the main things that is super important for you guys to know is how to clear headers before descriptors. Let me rearrange these cameras a minute and see if I can't get a better view for you guys while y'all are working on that one. Get this one out of the way a little bit. Might help. These books. Oh, the microphone. Okay. So what I'm talking about is if you go to, let's see, code 33881. Can you tell if this code is a correct answer as it is written in your book? 33881. Hey, Mom, you cannot use your 2023 books anymore, my love. You have to get a 2024 or a 2025. They won't let you sit with a 2023 book anymore. Be sure to just Google 2024 CPT book and see if you can't find somebody selling some on McCary or in my Discord group that you can purchase cheaper. And you'll have to move your notes, unfortunately. 33881. Thank you. Appreciate it. All right, awesome. Code CPT code 33881. If that is available answer, do you go to that code and look at it to see if that is the correct answer? Is technically my question. 33881. Right. Good, Samantha. Yeah, you cannot look at 33881 because 33881, if you notice, it is indented. It's moved over. The wording in front of the descriptor is moved over. That means it's a child code. You can't tell what you're doing in this procedure if you run to this code and read that descriptor. It isn't going to help you in general if you're not really familiar with these codes. You need to go find its mama. Sometimes the mama is right above it, and sometimes it's, 5 or 6 pages away. You have to stop and make sure you go look at mama. Mama is endovascular and all arteries, right? If your other available answer, let's see, what was this one about? This is about endovascular descending aorta, okay? And this is one that is not involving and if you look at 33895 is our other one, 33895. It's also a child code, and it's also saying the word not as its very first word in its descriptor. So is 33881. Not involving a certain part. This one is not crossing a major branch. You can't do anything with that. They're both parent codes. Start off with endovascular, endovascular. One of them is a repair. The other one is a repair too, but it repairs a stent. This one's going to be repairing the aorta. So those differences are what you look at. Learning how to do that is the difference between passing and failing. If they're going to give you child codes, you have to make sure you go to the parent, look at the parent. That is the code that you will compare with the question to see which answer is correct. It gets really difficult, especially in the digestive system, when some of our parent codes are really, really, really far away and they have a lot of children codes. Over here in the nervous system too, oh my, it gets crazy back here with the spines and stuff. Especially if you are in these different approaches. We're transperpendicular, we're anterior, we're lateral. Here we're anterior, but we're also anterior and lateral. And then they'll pick a code that's lumbar in all of them. Every single one of them, they'll pick the one code that is lumbar, like 63056. So 63056 versus 63102 versus 63267. They're going to give you 4 different lumbars, and they're all going to be child codes, and you running to that lumbar code isn't going to do you any good. You need to figure out which one is its parent. Compare the parent with the parent of the other child code that was also a lumbar. being able to know the differences between all those lumbar codes, very vital, will help you tremendously figuring out those differences. And that's why we group a lot of these codes. You know, when we're making these notes, when you're doing this little groupy thing with the different colors and stuff, it's not just for show. You need to put down your differences. Both of these are laminectomies. Both of these are for excision. One of them could be for an occlusion, and one of them can be for an evacuation. This one is arterial and venous. This one is intraspinal. This one is also for a malformation of the spinal cord, but this one is for anything other than a neoplasm. No neoplasm. No neoplasm. Anyway, bundling them, putting your one-word differences. If you get lumbar here, you get lumbar here, you get lumbar here. Knowing those differences between the parents, vital. Vital for the exam for sure. All right. Let's get back to this E&M question for tonight. Get this off the screen so you guys can see it. How's TikTok doing? Do they indent for add-on codes too? Yeah, add-on codes are indented also. Those ones will never be coded by themselves as the only code for the procedure. Those are always coded with something else. And you do not add modifiers in general to any of the add-on codes. The parent code you might add bilateral or some other modifier, but an add-on code, the one with the plus symbol in front of it, you will only multiply times itself for how many other extras you did. Hey, Christy. Good to see you. She's working through some errors. Awesome. She's doing claims reconciliation. I'm a coder as well. I'm trying to become more knowledgeable in surgery coding. Awesome. I hope I can help you out. Hey, Christy. She's new to all this and she's trying to take it all in. Well, all you got to do is pass the certification exam, and I teach from the exam point of view. You don't technically need a course. You can do this as self-study and then just pass the one exam and get your certification. So what I like to do is look at the answers first, because our exam for becoming a medical coder is a multiple choice quiz at this time. And knowing the differences between the E&M codes is super helpful. 99291 is critical care patient. And then 99232 is a subsequent follow-up hospital visit, meaning they were admitted on a previous day and you're coming around and doing rounds and seeing them today. Would this patient be critical care because you're doing CPR, you're doing something to keep the ABCs going, right? Airway, breathing, circulatory system, the blood's moving. You're trying to keep the ABCs going. If they're here, they're blue usually, right? So we'll check on our patient here and see what's going on. Look for the patient's status. Physical location does not matter. Just because they're in the ER or they're in an internal medicine physician's office doesn't matter. It's what they call patient status, meaning what does the physician consider this patient? Our patient is in respiratory failure. The MD intubates and vents the patient. Documents total critical care time is 30 minutes. What would we be coding for this one? Is this patient in critical care, or is this a subsequent follow-up hospital visit because they were already admitted? Just decide that part first, because that'll get you down to a 50-50 shot, right? It'll either be A or B, or either be C or D. I hope to organize some more small classes, groups. We did one last night with some practical coding exercises. We had about 7 or 8 in there where we took just patient charts and we went without available answers. How would you code respiratory failure for this patient? What would you look under the alphabetical index? For the diagnosis code and or for the procedures, how would you look up the procedures? I was trying to look up nailing a patient. They nailed a bone back together. It was funny. So I looked under nailing last night. But anyway, so we did that last night. So they do happen. Sundays I do workshops once a month where we get together, and those are more for the certification exams to see if you're ready for your exam. But as soon as things calm back down, hopefully I can start up some more smaller classes. We used to do a duck class on Fridays where we would get together and work on harder practice questions, but for right now I don't have any available just because, well, I got jury duty this week, and then yeah, it's crazy. Life is crazy. I'm working on it. I will let you know. I do offer one-on-one tutoring. You can schedule that on my website. You can schedule just for advice if you only want to schedule just for advice, or if you want to schedule a practice exam to see if you're ready for your exam. You can book either. Do those on Tuesdays and Thursdays. Go-Kart has a tutoring scheduled with me on Thursday, but if I get picked for jury duty, we'll have to reschedule that for this weekend or something. So I'll let you know. Thanks, Elizabeth. I'm happy you're here too. I'm happy that it makes a difference. So with this patient, just because it says we've got total critical care time doesn't mean we can always bill it. We have a guideline with this one. If we look at our codes inside our CPT book for critical care, we've got our 99291. Somewhere around in here. It's usually one of my favorite E&M codes because you don't need a level of care like low, moderate, high, those kind of things. You just need time. Our guideline says less than 30 minutes, use appropriate E&M code. What we have in this question is that we did an intubation, which is included inside that 30 minutes right there. Well, we can't bill for an intubation and get paid for that procedure code, but also count the time to do the procedure as another CPT code, right? So if I'm getting paid to do this procedure, which is intubation, I have to take the time off of the total critical care time. So for billing intubation, I'm going to have to take 5 minutes off of total critical care time. Even if it took me 2 minutes, 1 minute, it doesn't matter. Any minutes off of 30 minutes, according to this guideline that's in our little chart right there, less than 30 minutes, use appropriate E&M code, means that we still cannot bill for critical care because we didn't spend 30 minutes trying to get them breathing. We spent 28 minutes trying to get them breathing, but we also spent 2 minutes putting in intubation. But we got paid for that 2-minute time. If we counted the 2-minute time and we billed for the 2-minute time as a separate CPT code, that's fraud, and you could get fined thousands of dollars for that. So they want to make sure that you understand that guideline before they put you out on the floor coding. So that's why you will see an example like this on the certification exam. If they're saying anything about total critical care time and it's near 30 minutes or right at 30 minutes, you know it's probably a trick question and you're probably not going to be able to bill critical care. They just want to know, do you know that guideline? And because they've got this little extra sentence here that says which includes time performing intubation, you know you can't bill it. So we're going to get rid of A and B. And then if you are going to bill for intubation, you have to have your 25 modifier because you did an E&M visit and you did a separate CPT code. You did an additional procedure, right? So you know our answer is going to be C. Here's our next one you guys can work on while I check up on chat. I have E&M 2025 notes already up on my website. They can't go on Etsy because the file size is too big. So they're on my website at medicalcodingbyjen.com inside the shop. It also comes with a cool E&M mini study guide that takes each set of codes and puts it in a kind of like Excel sheet. Okay, if you're going to bill like critical care, here's what you can do in this box and here's what you can't do in this box. So that each set of codes has its own little cheat sheet thing that I made. So it's pretty cool. The 2025 E&M code notes are up in the shop. That guideline, Samantha, is, well, it's on page 29 in my book, but I'm in the 2025 CPT book. There is that total duration of critical care chart that is with that 99291 code. Yep. What's your question, Samantha? If you're going to turn your 2024 book into a 2025, yep. Easy to do. I already did it. I have some notes that you can print out from my website that will turn your ICD-10 book or your CPT book into a 2025. That way you don't have to buy a new updated book. Where is the 2024 book? Do I put the guidelines of the cellular gene therapies? I put them in my notes that you download. The ads, gotcha. I have a document that you can print out from my shop that's in at the medicalcodingbyjen.com that will turn your 2024 book into a 2025. Most of the time, guidelines aren't an issue. You just need to know what codes will not be allowed to be coded with that, and which codes can you code with it, and which modifiers go with it, and my notes handle all of that. I have pictures of the guidelines or whatever else I wrote in the book, printed and handwritten for you on the page where you should put them, where I thought that was the best place to put them. You get a picture of what it looks like in the 2025 book and then what it looks like when I put it in the 2024 book. If I didn't write it, then it's not going to be needed. This question for IA13, number one, can you go to IA13? Do you know how to look that up? Do you know what it looks like in the ICD-10? Do you know what they're talking about here? What each one of those means and how to find it if you needed to? Just curious. That particular guideline, when using a code for category D63, what is necessary first? Do we need a patient's blood level? Do we need a primary diagnosis? Do we need a chronic? Do we need an acute? And I guess I've got the answer down here already as C, the chronic condition that is needed, that is causing the anemia. That's the one thing that you need. But it would be cool, though, to know and make sure that everybody knows exactly what IA13 means. Some people, they ask later, and I see it in chat afterwards that they don't know what that means. But just want to make sure that everybody knows how to find IA13 if they needed to. If I missed your question, be sure and ask again. Thank you so much, guys, on TikTok. You guys are awesome. Got 250 likes already. Thanks for sharing the live. How many do we have on YouTube? We got 28 on YouTube, 11 likes. Yeah, that's pretty cool. So, what they mean by I13 13. Let me show you. Let me get back to my document here. And that. Bring up this book and turn back on this camera. So, IA13 means you go to your ICD-10 book, you find your guidelines, wherever they're at in your table of contents. Sometimes they're in the front of your book, sometimes they're in the back of the book, but you're going to be looking for your table of contents. They're broken up by A, B, C, mostly they'll just start off with either a letter A, B, or C, and then there's numbers in between. So to find what we're looking for, that IA13, forgot to tell you about section I right there. There's your section I. Then we have section 2 starts right here. Then you're going to have section 3, section 4, and then appendix I. Inside section I, you have A, B, and C, and that's in general mostly what you're going to use. And then you got some sections, section 2, section 3, section 4, and appendix I. So inside section I, or 1, you've got A, B, and then C, and then each side of those you've got numbers. So they told us to go to I, A, and then we're going to just go down here to number 13, which is right there, where they're talking about etiology, manifestation, code first, use additional, and in diseases classified elsewhere notes. They just wanted to know, did you know how to use this one piece of paper that's in the beginning of the guidelines, follow the section 1 or section 2, section 3, section 4, or appendix I. Find your way to specific guidelines that are either in sections A, B, or C, right? And then you get down here to your anemia guidelines of the coding first. A lot of the questions on the exam are about the books and knowing whether you know how to utilize them or not. Because all the anatomy you need, or any of the definitions, vocabulary, it's all located in these 3 manuals. So learning how to utilize these is super helpful. My camera is falling low. There we go. In HitPix, Category 2 modifiers, where would we append a new wheelchair purchase? It's going to be GM. This one again's got the answer down there. Why do I have the answer down twice? That's so weird. Of course, that ended up being NU for our new equipment in our HIPPIXs. Not every modifier is located in your CPT book. You do have a whole list of a bunch of other modifiers, and they're all listed in your HIPPIX book. So be sure to know where those are at. What about this one? For all of our vascular injection procedures, what is included? Is it all local anesthesia, our catheters, our selective catheterization, or all of the above? What would be included? Ooh, if I missed your message, let me know. Can't see the question. Can you see it now? Is it any better? Hey Jasmine, good to see you. Thanks for sharing the live. No idea what you are looking at. Aw. That's the rough part, is because they let you guys get your own versions of the ICD-10 book, and they can be different versions, and then they put stuff in different locations, and it's really hard when you don't have the same book in front of you as, you know, somebody trying to teach you something. I guess I need to go get every single version of the ICD-10 book out there. I don't know. What is included when you're doing vascular injection procedures? It depends on which certification you're going for. If you're going for just CRC, all you need is the ICD-10 book. If you are going for CPC or CCS, you'll need a CPT book, an ICD-10 book, and a HIPPIX book. And if you're really going to do CCS, I think they require a PCS book too. This is what the HIPPIX book looks like. Need one of those. If you're going to do an AAPC version of a certification exam, I recommend their version of the HIPPIX and ICD-10 book, because they have decision trees and other information that are included that are not available in other versions of the books. I don't recommend you purchase them from AAPC because they charge too much for shipping, but you can purchase them from Amazon and other places that are for free shipping. But their HIPPIX book has almost 800 pages in it. It has correct coding guidelines, 100 publications from CMS, other rules and regulations that aren't available in other manuals. So it is handy dandy. You're welcome. What do you guys think is the answer for this one? I hate those ads. So sorry. Let's give out some YouTube memberships for free to some lucky people that are on the YouTube channel. You will get access to all of the free workshops, replays, the podcast, all of the replay duck classes. Thank you, Lynn Lynn. She must want me to go live longer today. She is tossing out some super chats. Thank you so much. We got Mallory, Sam, Danny, Away, and Med that all won YouTube memberships. I hope those memberships are super helpful. All right, the answer for this one, it's not all of the above, it is A this time. So just all the necessary anesthesia, the needles, the catheter, all that stuff, the power injections, pre and post injections are all located inside those for sure.
Linlin07 donated $2 through Super Chat. 5.00.
Yay! Thank you so much, Lynn. All right, we've got another E&M. No, this is not E&M. This is medicine section. All right. So the first thing you do is don't read the question. Go to the differences between those CPT codes. See if
JP Gall donated $2 through Super Chat. 2.00.
Wow. JP, thank you so much. Let's go to our 939. I will stay longer and go live longer if y'all fill that goal up today. 3325. All right, if we go to 93925, are we doing a duplex scan for 2526? 26 is a child code. Remember, you can't do nothing with it. 30 or the 23.
Yasmin Sandoval has become a member.
Yay! Thank you so much for becoming a member of the YouTube club. With that membership, you get access to the podcast where I'm reading out the ICD-10 guidelines, guideline by guideline, and then telling you what it means in layman's terms. I'm also going through all of the E&M section. I've got that all done. I'll read you the sentences that are in the E&M guidelines and then tell you what that means. So you can make notes and adjust that area. That's really cool. You get access to all the old workshops so that you can watch those replays. Each of those workshops have 75 practice exam questions in the same pace as the certification exam. So if you can do those workshops and get 90% of the questions right with me and get to all the codes, find the codes, get the correct answer, and get on and get done with them all in the same time that I do, then you know you're ready for the exam. So those are great ways to study. So under these extremities, arterial studies, there's limited, complete, there's some non-evasive ones, then there's some that are called duplexes, some are bilateral, some are unilateral, all kinds of things to think of and keep up with. What answer do you guys think is correct?
Linlin07 has become a member.
Yes, there are podcasts. Jasmine can't find, but she doesn't, if she doesn't have her book in front of her, oh, that was somebody else. Can someone tell me where to find that code from 2 questions back? JM. It wasn't a code, it was a guideline question. That's right, about the anemia. It depends on which ICD-10 book you have. It won't be in the same location. And it's about looking and knowing how to find ICD-10 guidelines based off of just having the guideline number. So the 1A13, are you able to go to 1A13 in the guidelines? Do you know how to use that? Do you have the 2024 AAPC version or Optum or some other version? Which one do you have? It depends on tomorrow, Lin, if I have jury duty or not. And my oldest is trying to plan a trip to Mexico City for the end of January to maybe the 1st of February. So it might be tight, but I bet I could get you in. We'll see. It depends on if I've got jury duty or not. You do have the 2024 AAPC version of the ICD-10 book. Okay. Oh, where's mine? That's 2023, 2022, 2024. So, sorry guys. Hopefully, hopefully I can. I won't know until tomorrow. So, if you have this book for AAPC, the first cover, second page, it's all advertisements, right? So, you got your table of contents. Then the next page is what we're talking about. This page right here. Do you know how to find right here at the bottom where it says ICD-10 Official Guidelines for Coding and Reporting FY 2024 ... G1. Right underneath that it says Section 1. Okay. And then the next thing that I was telling you guys about is to find Section 2. It's on the next page. This is Section 2. There's Section 3. There's Section 4. And there's Appendix I. That's the first part. When they advertise something and they say, go look up guideline IA13, they want to know, do you know, can you go do that? I keep calling it an I, but I guess it's a 1. It probably should be just a 1. But do you know how to go find that? So the first part of that is finding where Section 1 is, and that's right here. Then you find the A that's underneath it. There's A, there's B, and there's C. Those are all under Section 1. Section 2 has an A, B, C all the way through K. Section 3 has A, B, C. Section 4 has A, B through Q. And then you have Appendix I. So, can you go to Section 1, Specific Guideline A, and then find number 13, which was the manifestation conventions. It's also the code first. It's also the guideline for use additional code, and in diseases where else classified. They were just wanting to know, could you go find that? And another place where you can find that is if you go to G4, the guideline starts right there at the number 13, right there. And they were talking about the guideline with D something. They have code first, use additional sequencing, and the manifestation. They have that all listed right there. I have the purples decided not to write. The G's, all those other ones, but that's in basic what they're talking about and wanting to know if you know how to utilize it, if they say anything. A lot of times, one of their favorite guidelines to pick on is, can you find IC R. So JM, can you find, we've already done that one, but JM on TikTok, can you find the one that's ICR? And to find that, you would have to probably watch the YouTube video, because TikTok's not going to show you what I'm showing on the YouTube video with the downward view of the pages inside the ICD-10 book. So switch over to Medical Coding by Jen on YouTube. I'm streaming live there. You can rewind the video just a little bit and it'll show you exactly what we're talking about in your book that you have there at your house. If you go to section I, C, and come here to R, this one's always on the exam. This is the one about malignant neoplasms associated with transplanted organs. That's on G13. And that guideline is usually always on the exam. They like to test about it. When you get to page G13, you're going to look for the letter R. When you get there, let's see, QR is right here. And then that way you can find it. Malignant neoplasms associated with transplanted organs. This will tell you that you're going to first assign the appropriate code, which is T86. Then you're going to code the complication with the organ, which is the C80. And then you're going to code any specific malignancies that went along with it. It'll tell you which one to code first, second, and third. And that's what they're doing, is just trying to see if you know how to look up any kind of guideline. If they only give you the reference numbers like that, are you able to turn in your ICD-10 book and go find them? And that is a cool little walkthrough on that for sure. Alright, back to our CPT coding of duplex scans. Did we do a complete bilateral non-invasive, limited, duplex lower, unilateral, bilateral? What we got going on here? I lost my chat. Lost my YouTube stream. Where did it go? There we go. Pop out chat. Everybody got A? I think y'all all had A with this one. Hey Twinkle, how's it going? Girl, I got jury duty in the morning and they done been texting me all night long saying don't forget to show up. It's an hour away from the house. I haven't had to put on pants in a year, so I had to go throw stuff in the wash machine. I gotta wear something other than house slippers or tennis shoes tomorrow, so I'm already dreading that. Ugh. Working from home has certainly spoilt me since 2013. I only have to go in to work one day a year for an annual audit. When I was working, I just recently retired as of May 31st, but that one day a year certainly spoilt me. Every once in a while, if I won an award, there would be a second day that we'd have to go. I'd fly into California, LAX, and we'd attend an award ceremony there, but that was living the dream that I want to pass down to you guys, is to go into work one day a year, you know? I wouldn't even go in for the Christmas party. I'm like, no, if I win something, y'all can mail it to the house. And they did one time. I won some sort of tablet thing or something one time. I hope all of you get the medical coding job or auditing job. I hope all of you become auditors. It's way funner to be an auditor. And work remote from home. An injection of this type of contrast material is part of what with contrast? CT, CTA, MRI, or MRA? Which one of them would be with contrast? Is it muscular, arterial, vascular? What do you guys think? The previous question for your vascular injections, it's in the guidelines right before you start coding your catheterizations. So wear your catheterization codes. Where is your selective and non-selective catheters? Those are pacemakers. Where is our selective catheters? That's pacemakers. That's nerve stimulators. Where am I at? Those are valves, 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 cabbages. catheter. Can't never remember. As soon as you get used to where things are at, they give you another new book. So just hadn't gone far enough yet. So your catheterizations, so you're looking around codes 36200 code area. You've got your vascular injection procedures. It'll tell you what's all included in these in the guidelines right before you start coding them. So check those out. They even draw pictures of the items that are located in those areas. So they write a little paragraph, tell you what's all included, and then you start coding that stuff. So check out that area, be sure and tab it so you've got it for looking up the answers. All right, this one also. That's okay, Alexis. You can always rewatch it. Samantha found it. Page 807 in the 2024 book. Oh, what book I got? I got the 2025 book out. Oh yeah, intravascular stuff. Yep. Heart catheterization, placing of catheter placement procedures. Yep, that's another good place for it too. Excellent. They've got a whole list of catheter placements and injection procedures, and then they list out what's going on inside each one of the procedures. Yeah, awesome. They've got the non-selective with the selective. Yep, perfect. It's located with the header that says heart catheterization. Yep, perfect. Excellent, Samantha. We are D, intravascular. Perfect. What about this one? We doing a 92920 with the 21 or not? Does it need to say percutaneous? Coronary atherosclerosis went and had a P, T, A, C, or PTCA. What does that mean? What is if you look at the words of the code, right, the CPT code descriptor, P, T, C, A. You see how AAPC will not want to say what the CPT code descriptor says, but try to use acronyms or AKA other terms that mean that, so that if you're unfamiliar and timid about the book, right, you might not know that PTCA, right, is actually the name of exactly what that CPT code descriptor says it is. Percutaneous transluminal coronary angioplasty, right? PT, yeah. It's all the same thing. Oops. I keep moving that instead of the video thing around. Isn't that cool? So it technically does say percutaneous. It doesn't have to say the word because it's got the acronym there beside it. Oh, it took me years to see it, Samantha, to realize, oh, that's what that is, yeah. And it's not the only one. There's a lot of other procedures that are acronyms, or you can call them something else. But if you go into the CPT code descriptor, you'll see the actual words written out. So, yeah, it just takes getting familiar with the books. Last page of CPT book, yep, does have the common abbreviations, and be careful about that, Emma. Don't forget that some of those acronyms in the back of the book also have like two of them all listed in one. So like if you go to IVC, it might not be intravenous whatever graphy. There's a second one after a comma. They can also call it an inferior vena cava, right? So there's two of them listed in that one. So don't assume that it's not one thing. It could be a second thing. So they do have multiple words written there of multiple meanings. And then one other place that you need to be able to know where it's located at is like, I think around page 600, because all your acronyms are not listed on the back cover. There is a specific list for lab and path that are listed in a different spot. So we've got these on 618. There's 3 pages of them here. 4 pages. So be sure you know where to find these acronyms too and definitions, because you could be here that you need to look up some acronyms too. So that's handy to know where that page is at. In the 2025 book, it's 620. I do have a list of like codes that you should tab or know where the charts or the definitions of things are, listed on my website if you want to download it, and it'll tell you what pages to go to, and then that way you can highlight them and know which charts or pages might be super helpful to know where certain things are in the book for the certification exam. All these definitions are all super handy dandy to know where to look them up at. Page 635, if you have the 2025 book, has a whole list of definitions of a ton of lab and path words. Super cool to know where that definition list is too. So don't forget to go through your entire book and write down the page numbers, where the codes are located if they're red. It's easier to find the codes if they have like a hashtag on them. To find it here as the hashtag and then go find it where it should be, because it'll be red, and at least where it should be will be in alphabetical order. The hashtag is out of order. If you go from the red codes to look for them from here, it will be very difficult to find them because they're out of sequence. But every time you find a hashtag one, just go where it should be, and you'll be able to put the page number down where you found the hashtag one. That's an easier process than going in reverse. I'll put down the column number where it's at, because every single page has 2 column numbers, 1 and 2. You ain't got to do all that, but I do it for you in my notes. But if you just at least get the page number down, that'll help, because there's nothing worse than getting down to not being able to find the codes that you're looking for because they're out of whack. That's extremely stressful, and some of them are, 2 pages away, 10 pages away, or one of them's 900 pages away, and it throws everybody off. So it's a nightmare. First, go fix that. That is the first thing you fix on these books, is to mark those. Other things that I like to mark in my notes is a color code. Like all the blue codes right here, they're all done peripherally. Peripheral, right? The pink codes, these are all done centrally. Central. So when I look at this page, and if I was given 4 codes as a possible answer on the exam, I know with this page, these are peripheral, central, peripheral, central, peripheral, central. The first thing I'm going to look through for the certification question to see what my answer is just simply looking for the word peripheral or central, right? And that will help get me down to a 50-50 shot. Then they'll probably give me 2 peripherals that are child codes, and I got to figure out if I'm repositioning or removing one. And that's it. It makes the exam super easy if you can figure out on each page what is the differences here. What's going on here that I can see as a pattern between these codes, that will be a pattern in the exam question that will help me eliminate answers and get them down. 2 of the procedures are open procedures. These 2 are open procedures. Other ones will be closed or percutaneous. So did I go under the skin, or was I an open procedure? I mark those differently too. So that is what I do when I start out on these codes and start making my notes. It gets kind of crazy because I like to add a lot of notes, but this means something to me. I can see here these are all pulmonary. One of them's ascending, one of them's descending, one of them's central, and 2 of them are superior vena cava. Because I've got them all color coded, I know that if I'm here, all I got to worry about in my question is, am I ascending, descending, central, or superior? That's it. Go look through my question, figure out which one I'm in. It's probably going to end up being a difference between these 2 because they're both alike, superior, superior, both pulmonary, both pulmonary. All right, what's my one word difference between these two codes? One uses one lung, one uses both lungs. And that makes the exam a lot easier. And it'll tell you in these guidelines what is your differences between the codes. I'll use my guidelines highlighted here. Some of our procedures are diagnostic, some of them are right and left of the heart. And then I'll go through here and color code these right and left. Makes a super cool thing. This is what I was showing off TikTok. Sorry, I forgot to include you guys in on it. Where were we at? We're right here. So we're at the codes 33965. So this whole page, peripheral, peripheral, then we've got central, central. Then these are all peripheral. These are all central, peripheral again, and then the last two are central. So I just did two color codes, blue and pink. And then that gives me a really cool pattern to look for. The last set that I was just looking at right here was our pulmonary artery procedures. These are all pulmonary. But my only difference between them is ascending, descending, central, or superior vena cava. Two of them happen to be superior vena cava. Only difference is the one's using one lung, one's using two lungs. So some of the procedures are open procedures, and I circle those as an open procedure, and then if it's percutaneous, that means we're going under the skin. I just draw a line under it to show that that's a percutaneous procedure. A lot of the cardiovascular is whether we are atrial or if we're atrial and ventricular. Did we do both? So I'll go through here and circle the ones that are just atrial, which ones are just venous and or ventricular, and then which ones are the combo codes that have both. And that makes a big old difference. But it makes sense to me. It's not for everybody. I think it's helpful, but they do go over in the guidelines right here what's going to be your differences between all these codes. That's where I'll decide what my color coding is, and then I'll do it here. A lot of these codes in the very beginning of cardiovascular is just a difference between arteries and veins, whether we're peri, going around the heart, or are we going under the skin, you know, that kind of stuff is are we doing just the lining around the heart, or are we going into the heart? That's the big differences. If everything is peri, you know you're up here in the front of these codes. I've got those all highlighted in baby blue for peri. And then once we go open into the heart, I've got those circled in green for open. But back to our acronyms here. In our practice exam question that we were working on, if we have a patient with CA, coronary atherosclerosis, and they underwent the percutaneous transluminal, all right, of the left ascending, what is the first LD? Did we decide on answer A, B, C, or D? Are we going to code one code or two codes? I lost chat again. And we'll do pop out chat. Everybody said B. What about C? What's going on with our C here? We've got, get rid of that out of the way. The add-on code 21 is used to report the blank to a branch off to the left anterior descending. We started out at the coronary artery and we ended up in the left anterior descending. So that is both. We needed two of them. What about this one? We've got our 93530. What's going on in that code? 93530. Ooh, nothing listed there. 935. 935. 30. Nine 3581. If we have a baby born with a ventricular septal defect, which is VSD, the provider performs a right catheterization, the transcatheter closure with an implant and our approach was percutaneous. Probably ought to be able to utilize one of these days these catheter placement charts that they just put in for our 2025 year. They have this fancy little new chart they put in. Our 93530 is under a different blue header. 30, 35, 30. $935.81 is under the header of repair of structural heart defect. This patient does definitely have a heart defect. You got it right. That's awesome. Good job. I work for a hospital, but we have a separate billing department. Awesome. Do you mind telling me what type of jobs you have where it doesn't require billing? So, one of my favorite places for a job, let me pull this up for you. All right. NCQA. If you go to NCQA website, this is a place that medical coders can go into, and we do HEDIS measures. So let me get this page into focus for you. I don't like the way this one's set up. Hold on. Let me see if this one's any better. There we go. So if you go to the NCQA website, get you guys back in here. NCQA website, right there in the center of the website page is called HEDIS measures. This is what I did for years. We measure and give report cards to physicians and medical groups based off these conditions right here. Did they get all their wellness vaccines taken care of? Did they do lead screening on all the children that are assigned to them? Are they doing pap smears unnecessarily? Like, it's not required that you get them done every year. It's supposed to be every 3 years. Are they doing colorectal screenings by the time somebody's 50? Are they capturing chlamydia screenings at age 13 and up on every kid right here? And that can be just a urine sample, just having them pee in a cup. There's a lot of different measures here, and people will pay you to go hunt them down and find the medical record of their flu vaccine that they had done at CVS that doesn't talk to their medical records, right? The ones that they had done at their VA hospital because they used their husband insurance instead of their HMO health plan. A lot of times it's just tracking down records and getting them put into a chart that the other health plan has, or confirming that the physician did the measurement somehow or another, whether they didn't capture it because they don't capture CPT codes or whatever. But this is a great area to go into to look for positions, is to be HEDIS, abstractor, just anything with the word HEDIS in it will help out when you're looking for jobs. You don't have to be an expert. All the answers are right here. They will give you legitimately the CPT codes that go right here, why it matters. They've already got every single PowerPoint presentation that you could ever think of already made for this. You can go to educational and training area right here, and you can watch some virtual training and seminars on this all for free and become a expert in something that sounds fancy, but it's not. It is super easy. They will give you all the codes that go with each measure, and you just go hunt up the medical records. Love HEDIS measurements because you're not billing a patient for anything. You are just making sure that they're getting the health care that they're paying for, right? Or that they're entitled to based off age and whatever else. So I love HEDIS measures, and there's a huge market for hiring people that understand how to look up a CPT code and how to go find a medical record, right? Another place that I love to go to is if you go to my website, medicalcodingbyjen.com, go to the free resources tab right there. That is the second resource. Go to the FAQ page. It's just facts, your favorite questions to ask me all the time. Go to the third sentence that says, where's the best free resources? And totally free, come here. And there is a link right here that says CMS free classes. Go here, click on that button. It'll take you to the government website where they have free web-based training and certification courses. available to everybody. These are courses that you can take unlimited amount of times. No one's going to track you. My employer used to send me here every year for fraud and abuse training because it's required by law. But they have an ICD-10 coding course right here that you could take. Other places that you could do that people love hiring for is if you took these two courses for Part C and Part D, coverage denials, appeals, and grievances. If you took these two courses and learned how to work on appeals, grievances, and determination stuff for Medicare through these two courses, then you could add these certifications that you will get for free doing these two courses, and then you could put them on your resume and start looking for jobs in appeals and grievances and determinations. Right now, you can work those all you want from home. There's a million jobs doing that. I love it. Be sure and do your fraud and abuse training that's already here too, because most employers have to send you to get this done anyway, so you might as well get it done. These are all free. You can take the course over and over and over again until you do pass, and then it'll actually issue you a certification in it. So it's really cool. Love it. Be sure and check out their website. You can also look up like EHR data warehouses. I loved working for a company called MDX. I loved their data warehouses, and I became a super user of their data warehouses. So nothing's uniform in the United States, right? As far as healthcare goes. So if you just Google EHR data warehouses and you start to look through some of these data warehouses, some of the standard ones that are regional throughout our area, every medical group and doctor's office has to capture your claim information and health insurance information, and then they got to send it to Medicare, which gets sent to the World Health Organization. It gets sent to everywhere. Well, those entities do not talk to each other, and none of them are set up universally. So somebody has to create a data warehouse that will take the data the way that that medical group sets it up and puts it in their medical record system, and translate that computer language into something that will be accepted by Medicare or Blue Cross Blue Shield or Optum or the World Health Organization. So being a super user of an EHR system is really cool, especially when they're new startups and stuff and they're working on building a system. You as a medical claim person or a medical coder can actually help companies develop systems and tell them what doesn't work, what does work, what your office would love to see, what they wouldn't love to see. Or you can just simply try to break their system by entering in 25 different diagnoses on one claim to see if it goes through or not, and see if it doesn't work and what it looks like on the other end when it comes back from the health plan and it gets reprocessed. So it's not hard. It sounds hard, but it isn't. A lot of these data warehouses, if you go to their website, click on their sales team and let them know that you have been tasked with the job of researching new data warehouses for your medical group. Do they have any educational material for you? They will send you a ton of PDFs or websites, or give you a log-on and password, let you play around in their systems. So don't be afraid to reach out to some of the sales teams and become a super user of some of these EHR systems and stuff. So that's always another place that you can get a job at. AAPC, of course, has lots of jobs. posted, and underneath their your own membership place, there will be a local chapter area right here, and it will have job opportunities and a job board where your local chapter is posting local jobs and stuff. That is really cool. Also included in your membership is externship. They'll have a list of places that you can go to work for free and do an extended period of time of learning in a place through their externship program. So be sure and check that out. But even the makers of CMS, the book, the AMA, where we get our CPT book, right? AMA actually has job openings for people that are medical coders. This is also a place where you can look for employment and different job opportunities that are not billing or coding related. There are a lot of positions available here for many different areas of working in medical codes that are super easy to get into and not as bad as you think if you would come here to any one of their areas and look for careers, right? So you can search for positions here and see what's out there, what kind of different positions there are. Just be sure and network with other people that are in the industry. Don't forget about your AAPC local chapter. Talk to other people. But you can search right there for a ton of positions in AMA, AAPC, AHIMA. They all have positions available. But I love working HEDIS measures for sure. That's one of my favorites. That is not billing or coded related, but it still needs, or a lot of times it's helpful if you've got your CPC. Did anybody decide on which answer was going to be correct for this one? You know you're going to have your defect, right? So our code underneath the defect is our 81. We just need to decide, do we code it with the 30 or do we code it by itself? Do we need a new code besides our 30? 835, 835. Wonder which one they were looking at when it got deleted. We're doing ventricular. Okay, let me find one that's ventricular then. Which one would we use with that one? Or would we use it by itself? Let's see. See, under our other header for 3.5, all right, left, trans, catheter, 34, echo, those are right, wrong ones, combo, that does have intra, it does have ventricular. We're doing a right heart catheterization. This one's left. Intra. We're doing, okay, so let's change this to 93456. Four, five, six. 4, 5, 5, 6. Then, because that's with the right heart catheterization, plus it's a child code, So you got to go look at MAMA. MAMA is a catheter placement of the artery. It's a coronary angio. Did we do a coronary angio? We did a transcatheter closure with an implant is what we did with our right heart catheterization. Our 93456 is a right heart catheterization, but it's a catheter placement. An angiography. It is not a transcatheter closure with an implant. It's also under the header of heart catheterizations, where our 93581 is underneath our headers of repair of structural heart defect, right? Yep. So C, irregardless, because our 81 is our transcatheter closure of our septal defect with an implant. Yep. And they were just looking under for the parenthetical note. This is do not code that one with that one. I wonder where they put, do they still have a do not? They don't have a do not down there. Well, 38580.
Taylor Wren has become a member.
They have a 384, a 3451, 35. Yeah, those are all unhelpful. 30. But I picked 38456. 38456 is in that do not. Perfect. There's that do not that's underneath the 81 that says do not code 38456. We can change that to that so that our rationale is correct. There we go. Because it does say that. Perfect. Alright. Sometimes these questions have to be updated from time to time. Alright, according to CMS, what is the proper POS code for transpharyngeal Doppler coding? It'd probably be better if we took rid of that. That way you'd have to figure out what is a POS code. Alright, for transpharyngeal Doppler cardiac monitoring, would that be 11, 21, 22, or 23? Does everybody know where the POS codes are at? We have some POS TikTokers. It's too fun to be on that list of TikTokers. What is going on? Oh, that's Travi coming home. I gotta say something to Travis. Who's the best parent there is? Go to your room. Go to your room. Who is it? Why are you in my house? Why are you in my house? Who's the best parent known to man? Mommy is something he ordered before Christmas just now arrived today. So you know how Santa's super slow nowadays, mail and stuff. All right, everybody know where POS is? Where is that list? All right, our POS is. I can't. I got jury duty tomorrow.
If you don't get out of it.
If I don't get out of it, I'll maybe have to go look and be crazy tomorrow. But yeah, if I don't get out of it.
It's not hard to do.
Well, I know, but if I don't get out of jury duty, I'll miss his game. You have to take some videos for me.
I will. They're, because they're stunting together.
The very first page in your CPD book is your POS list. So if you are in a CPT book, does not matter what year, your very first page in it is your POS list. It's 2 pages. Starts with 01 all the way to the number 99. And you are looking for transpharyngeal Doppler catheter monitoring. What you will do is look in the 3rd column for the test that you did, which is right here, until you find cardiac monitoring. And then it will tell you what number you're at right here. So, Travis just got back from cheer practice. He has been gone since 6:50 in the morning. Child just got home from high school. They work them to death. Yeah, it's a long day for those kids. Yeah, that's where I'd like to know too, Jenny. So what happens is sometimes the answer is not provided in your manual like it's supposed to be, right? Sometimes they're pulling from knowledge out of the HipPix book. The answer to this question is actually inside your HipPix book. If you have an AAPC version of the CPT book, in the very back under the 100 publications in a random spot, they will talk about where transpharyngeal Doppler monitoring is located. If you have something down somebody's throat and you aren't doing it as a test, but you have it stuck in there because you need to monitor the patient's heart, where are they going to be? Doctor's office. 21 is inpatient hospital. 22 is on-campus outpatient hospital. And 23 is an emergency room. What do 3 of them have in common? This is an office visit. This is an office visit. And this is an office visit. These 3 are just regular office visits. The only one that is inpatient, you're admitted kind of thing is B. So the only one that's different from the other 3, you could also look at that and figure out what the answer is from that. What do 3 of the answers have in common? There will be one that is different from all the rest. ER is not an admit to a hospital. Just because you come to the ER doesn't mean anything. That just means you're an outpatient, you're free to go, you are not admitted, you are in a regular doctor office visit. Same thing with the outpatient hospital. Nothing's overnight, that kind of thing, right? So the only one that's different from the other one is 21. Now, it's not written in the manual for the cardiac monitoring, but because of this question, and because I practiced it, I wrote it in here. I put example, cardiac Doppler monitoring transpharyngeal. I always write it in every time I get a new book, every year, under 21. That way I have it for this particular question. I hope you get your books soon too. But hopefully that helps out. Hit Picks, page 600. That's awesome. You guys are awesome. Yes, it is 21. All right, what is the difference between NCD and LCD? Yes, POS codes are located in your CPT book. The ones that they like to pick on during the exam are the ER versus admit patients, like the one that we just did. They also like to do the nursing home ones. They're on the second page at the top. There's 4 different types of nursing homes, and knowing which one does nursing care, which one is just custodial care, those kind of things they like to pick on during the exam too. Let me make sure Travis is getting a shower. Okay, LCDs. Are they values, national level, medical necessary, or Medicare A? I try not to read the whole question. I try to pick one difference between each of the available answers when I'm working through these wordy questions. Is Travis getting a shower? Please get... No! They're being totally ridiculous. They said that he needed, online, that he needed a withdrawal form filled out and signed and brought with him, and I did that. And then when I went today, they said he needed his transcripts. So the other school hasn't sent his transcripts yet, and he can't go till the end. So anyway, please wash. Move it, Lester. Come on, Sammy. All right, guys. What was our answer for this one? Email letting me know they've been sent out, but nothing yet. Yeah, they're slow about shipping sometimes. B is correct. Perfect. What about this one? Radiology. 46 is in all of the answers. You don't really have to worry about it. Are we going to add a 50 to it? If we do we need a TC or a 26? What are these codes? 74150? Oh my goodness. I got a sneezy kitty kitty. And move the books out of your way. There you go. Alright. 74. 741. And 4150. The scan was sent to the office and the physician interpreted and documented the CT scan of the abdomen, showing a small mass in the upper right quadrant. What CPT code are reported for the doctor's office radiological services? Patient is at the doctor's office for a follow-up. They had gone somewhere else and had the chest x-ray and CT scan done. At the diagnostic center, the results of the chest x-ray were normal. The CT scan was sent to the office and the physician interpreted it. It said there was a small mass in the right upper quadrant. How would we build this one? Good job, guys. Everybody got it. Everybody was doing A. Perfect. Good job. Good job. All right, let's practice just a little bit of integumentary on the fly without any practice questions. Those are excisions. We don't need those. I need good old-fashioned, just a regular old. Ooh, I don't know where nothing is in this section because I haven't done the notes. Here we go. Okay. All right. So I always learn better, I think, when we're doing stuff like this. So I want to talk about codes 12001 through codes 13160. For your exam, when you get these practice exam questions, it's going to be a lot of body parts, a lot of upper versus lower extremities. They're always going to combine things like body parts in dealing with those issues. So what's included in your upper and lower extremities is also your trunk area. Be sure you know that your trunk means chest and back, right? And you are not talking about, no, you are talking about hands and feet in this area. There are other areas, like in the Moss surgeries and stuff, when you do upper and lower extremities and trunk, that does not include hands and feet. So be very careful about that. Know which ones you can. But this right here does include hands and feet. Those are some good things to remember for sure. Besides deciding what body parts you're doing, the other area that you need to know about is, am I simple, am I intermediate, or am I complex? So simple means we're just doing just a layered closure. It's just single layer closure. That just means like just the subcutaneous level, right? Or percutaneous or whatever, you know. But if you're in intermediate, you're doing multiple layers. So like you might be, you know, muscle, layer, adipose tissue up to your subcutaneous level, dermis. So things that to think about is if your epi and your dermis, right? Epidermis and dermis, you're going to be, you know, doing a layered closure there. If you're complex, you're dealing with things like tendons, ligaments, cartilage, stuff that, you know, super down into those, and you're having to deal with that kind of stuff. Any kind of neuro, vascular, connecting any arteries and things back together, you're super complex. If you have a single layer closure, but you had to also clean it out before you sewed it up, if you had to clean it, like remove rocks, you get to upcoat it as intermediate, even though it's just a single layer closure. So that's the main issue that they are going to ask you about as a question on the exam. So if you have a patient who fell in the parking lot, whatever, on the way into your doctor's office, and they ended up with a 5 centimeter elbow to wrist laceration that was single layer closure on right and a 5 centimeter on the left with debridement, and then a So what would we code for something like this if we had a patient who fell in the parking lot, who had a 5 centimeter elbow to wrist laceration that was a single layer closure on the right, and then the same thing on the left. They debrided it, and then they used a steri-strip to close one on the forehead and another one on the knee. What would we code for this scenario? Anybody know what we would do? The first thing you got to do is look at your body parts, right? And see if everything is located in the same area. Scalp, knee, elbows and wrist. Are they all going to be in the same anatomical site? Are they all simple, intermediate, or are any of them complex? And then divide up your so if we had upper extremities, we got 10, but 5 of it is simple, and then 5 of it is intermediate. One two oh 32, and then the 12002. What do we do about our topical anesthesia or local anesthesia if we use our lidocaine so we can stitch them up? We give them a couple of shots in their areas so that we can do those stitches. Steri-strips won't need it. What's our guideline about that info also? Those are all things that they might question you on the exam for sure. Yep, and don't forget to put your codes in the correct coding area with your most difficult procedure first. So the 30, is it 32 for the 5 seminary? Yep. That will go first, and then your 04, no, the 02, not 04, will go next, because we don't code single layer Band-Aids and steri strips codes, because those are not reportable. We don't charge for Band-Aids, is basically what that is. And our local or topical anesthesia is not reported separately either. You can capture it for code purposes, but put 0 billable amounts to it is what we do. That way we can keep up with how much lidocaine we go through a year, and inventory issues is what we use it for. But we probably would have a office visit with this one, right? So a 9921, I don't know, a 3 or a 2. If this is an acute issue, it's probably in a 2. If they were already coming in for an established visit for a follow-up on their diabetes or something else, you could technically go on and do their 99214 for their follow-up on their diabetes and refills of their regular meds, add a 25 modifier to it, and add in your second visit because they actually fell in a parking lot and came in with a separate issue that had to be evaluated. You would have had to have done a history on their injury. You would have had to have done an exam on their multiple lacerations in their forehead and all that stuff. You probably could end up doing 2 office visits for this if the patient was being seen for something else already and they just fell in your parking lot. So you'd have 2 E&M visits. Your steri strips are included in your E&M visits codes. So you would only need to code your right and left, and you would do the 32 first and then the 02 for the other one. There is a guideline right here in this repair thing, the very last sentence, about adhesive strips as the sole repair for that region or whatever is included in your E&M visit, so that's handy dandy. Where your guideline is for your single layer of heavy contamination, that is located here in the last sentence underneath your intermediate repair. That is super handy dandy. Don't forget, there is a list underneath your complex repair guidelines that starts out over here about your heliacal rim, your something borders. There's a whole list of different types of procedures that are known to be complex. Be sure to get those and move those over to your complex repair list right here. I move those from the complex repair list to here. That way, if I see any of those fancy words, that I know that they're complex automatically if they've got those crazy words right there in those guidelines. Because the complex repairs are, you know, almost 3 pages away from those guidelines. So I make sure I have those moved over. Did I do integumentary last year, or was it the 2023? I can't remember. I did do them. This is the 2025 book that I've got right there. So our 2024, we're going to be around page. Skin replacement surgeries. Ooh. Took them all down. Yep. There's those different guidelines right there about those different borders and the different types of sutures. If they use retention sutures in your example, you know you're always going to be complex. That is super handy to know during the exam. If you see that type of word written down for a procedure, that is cool. All right. Everybody know about determining margins. Knowing how to do that for the exam is handy dandy. Okay, here we go. Margins. So if you have a repair or a removal, of something, and you need to figure up how much your margins are. Let's say if you have a 5 centimeter removal and you do a margin around that 5 centimeters of a 2.0, then your total that you're going to bill for is going to be a 9, right? That's because you take your 5 cm and then you take your margin and you do your margin twice, because it has to go all the way around your area, so they always count it twice. So that would equal 9. So whatever they say is a margin, be sure and do it twice. Normally, like, your margins will be, if this is 5 centimeters, your margin's going to be more like a 0.2 cm. And then you would just do plus another 0.2 cm. And then that would equal a 5.4 cm. That's more likely what you'll see on the exam. But it's not that bad of a math. If they ask you to do margins for anything, it's not too bad. Just remember, only one number is done twice, and it's the smaller marginal number. Moss surgeries in integumentary. The first thing you got to know about Moss surgeries is location. What body part? that will get most of your Moz questions down to a 50-50 shot, is if you just look for a body part. If you are that body part, that equals most everything. It's easier to go look in your Moz questions, whatever you want to call them, to look for the 13 body part areas, because this one's a big area, but 13 only covers legs, arms, and your back and chest area. Everything else including your hands and feet. I don't know why they don't combine them with extremities here, and they do in other places, but anyway, hands and feet and all other areas are here. So the easiest thing to do is, if your available answers are anything from 17311 through 17315, automatic, first thing you're going to do is go look through that question and see what body part did I do. If you are arms and legs and back and or chest area, you know your answer has to start out with 13, and that's it. That will get you down to a 50-50 shot. Each one of these numbers, the 7, 3, 11, the 7, 3, 12, and then the 7, 3, 13, and the 7, 3, 3, 14. All of them have 5 slides in them, or what they call in the questions, what do they call them? Blocks. They call them blocks. What they're doing is cutting a piece of chunk off of you, a piece of meat, whatever it is, just a big old piece of meat off of you, and then they're going to take it and then slice it into little blocks and then put it on a microscope slide. And that's what they're doing in this surgery, is your surgeon who's removing the piece of meat off of your skin is going to look at it under a microscope, and they're going to play another doctor. They're going to be not only your surgeon, but they're also going to look under the microscope and be your pathologist. They're getting paid to do 2 physicians' work for 1 surgery code, and they're going to see if they removed all the cancer or not directly during the surgery, right? So each one of those codes has 5 blocks in it. If they make more than that, then we can add to it if we need to. And that's where the 12 and the 14 come into play. These are add-on codes that cannot be coded by themselves, and they only go with each other's code. So only the 11 goes with the 12, and only the 13 goes with the 14. That's it. There's no flipping them around and doing an 11 with the 14 or a 12 with a 13. That will never happen. If you see it as a possible answer, then you can get rid of it. So if your physician goes to the body and cuts out a piece of meat, and they make 6 slides, but this one only has 5 in it, that one only has 5, that's where we would add another code for our additional slides. So that's where those extra codes come into play at. Super handy dandy. If we go back to the body a second time, that's where our second code comes into play, because we went back to the body and cut another piece of meat out, right? And if that second one did not require extra slides because it has 4 in it, then we're good. Our extra slide right here that needs to be accounted for is where our 15 universal code comes in play. That's that 7315 code, and it's for additional slides or blocks that were made over and above the 5 that are located each time we go back to the body and remove something. So, for example, if we had a patient who had something removed on their back, automatically you know they're a 13 code. So that's going to be your 17313 because we got the back. And they cut something off and they made 5 slides. Good. That's all included in your 17313. Perfect. Then the doctor goes back to the body and cuts some more off because the margins were not free of cancer, which means the area around whatever they cut off still had some abnormal cells on it. So they went back and made a bigger cut, right? So this time they made it into 6 slides, right? So that's where our 14 comes into play. Our 17314 has 5 blocks in it, but we still got 1 extra. So that's where we get to add our 17315 because of our extra block that we had out of the 5. Not too bad. Let me give you guys one to do. So we are removing Mo's surgery, whatever, on the nose. Okay. And our stage for the nose had 4 blocks. All right, what is our answer for this question then? Anybody got a clue? What would we do here for this one? Anybody still awake? So our nose, good Samantha, the nose is going to be 17311, perfect. Now what? close, Kanisha, close. Perfect. Our first stage, 4 blocks, is our 1, 7, 3, 1, 1. Our second stage will be our 12, right? Our 1, 7, 3, 1, 2. And we had 4 blocks, 1, 7, 3, 12. What do we do for this third stage? We need some more blocks here. What do you do? Our descriptor inside the add-on code for 12, the very first word says each. So what happens when you go back and you have another stage? What do we do with our 12? You can either, if you're ahima, CCS, they'll write it out like this. If you're aapc, you'll write it out like this, times 2, right? We did another 5 and another stage back to the body. So now we've got our 1, 7, 3, 12 again, because we have a third stage. We've got stage 1, stage 2, stage 3. Every stage will need a new CPT code. This one has one too many blocks, but they did do 5. 5 is included in here. 5 is included here. We did 10. We did 5. Yep. So we've actually, well, we only did 4. Sorry. Wasn't paying attention. So we did 4, and then we did 4, and then we did 5 more, but we got 1 extra lonely bird left over here because this one. So yeah, we'll add in our 17315. Yep. What if our number had been, let me erase this, 7. Now what happens when we have the number 7 right here? Because if you look at the CPT code descriptor of the 15, it says each additional block after the first 5 tissue blocks any stage. If you look at 14 or 12, it says each additional stage after the first stage up to 5 tissue blocks. This one does not say it's good for 5 tissue blocks. It says each additional block after the first 5, any stage. So that means that if we had had 2 extra ones out of our 5, we're gonna times that one, right? If it's 8, you're gonna have 3 extra ones. If it's 9, you'll have 4 extra ones. Crazy, crazy, huh? Gotta love my surgeries. I refused to learn this for my certification exam. I was like, no, I can't do that on top of everything else I gotta know. It's too much. But you guys, plus I didn't have anybody going over what the descriptors mean and what the heck does this mean either. So it was just impossible to read it and know what the heck was going on. But hopefully that helps out some. You're welcome, Samantha. Love to help. Love to help. Good job, Go-Kart. All right, guys. I hope this was helpful. I'm going to go hang out with Travis and see how his first day back to school was been. We've been live almost 3 hours. Thank you so much for all the super chats, the bonuses that, and Yasmin joined the YouTube club too. Aw, that's awesome. Thanks so much, guys, for hanging out with me. I hope I can get out of, and Taylor, you joined the coding club too. Hopefully I can get out of jury duty tomorrow and I'll be back on Wednesday night. If not, it won't be till this weekend because they're going to keep me in court every day. So I don't know. We'll see. Hopefully I can get out of it, but if I got to do it, I got to do it. I mean, it's not a hardship to go and be part of a jury, but it's an inconvenience. But, you know, it's not a hardship, and I don't want to lie and say it's a hardship, but they won't be happy with my salary that they have to replace me with. So I don't even know. The courts will pay for my mileage, which is going to be 70 cents a mile, 50 miles there, 50 miles back, and up to $300 a day for jury duty. So I don't know. That's crazy. I don't know if our court's got that kind of money, but we'll see. Anyway, I'll let you guys know as soon as I know about tomorrow, and hopefully I'll be back on Wednesday and Friday where I can do 2 more hours of free lessons. If not, it'll be this weekend, Saturday or Sunday. I just don't know when or what time yet, but keep an eye out on YouTube. Be sure and subscribe to the YouTube channel. That's completely free, and it will alert you when I go live on your phone, so that'll let you know. And on TikTok too for the TikTok following. So I hope this was helpful. Love you guys. I'm so proud of you guys. Everybody's saying thank you to Miss Alexis for some reason. Awesome. Hopefully y'all are all networking and helping each other out a whole bunch. Sorry, Emma, if I missed your question and I didn't get to it. Sorry. All right, guys. Love you guys. I will see you later on. I hope it's Wednesday.